Good morning. My name is Dr. Praveen Thomas. I'll be talking today on cerebral venous thrombosis nuances in headache medicine. In a patient with suspected CVT, we need to take a detailed history, sex-specific and hormonal history such as oral contraceptive usage or hormonal therapies, use of fertility treatments such as ovulation induction or IVF treatments, history of pregnancy, puerperium, recent miscarriage or stillbirth, hereditary or acquired thrombophilia, family history of DVT, pulmonary embolism, early strokes or unexplained miscarriages, past history of thromboembolism, systemic autoimmune disorders such as cancer or malignancy symptoms, weight loss, anorexia, night sweats, inflammatory diseases such as inflammatory bowel disease, Behçet's disease, oral genital ulcers, uveitis, sarcoidosis symptoms such as uveitis or pulmonary manifestations, connective tissue disorders such as presenting with photosensitivity, rashes, arthritis, and Raynaud's phenomenon, myeloproliferative symptoms such as pruritus after a hot bath, infectious or inflammatory precipitants such as recent sinus, ear, or localized infections, sepsis, tuberculosis, hematologic or metabolic factors such as anemia, PNH, polycythemia, dehydration, obesity or sedentary states or immobilization such as long travel, bed rest, iatrogenic or structural causes such as recent lumbar puncture, neurosurgery or cranial procedures, head or neck traumas, even minor with possible jugular vein injuries, recent initiation of medicines such as steroids, antipsychotics, erythropoietin or chemotherapy, environmental and physiologic stressors such as high altitude or prolonged air travel, and febrile illnesses or excessive exercise leading to dehydration. Drug and toxin exposures such as anabolic steroids, cocaine, or amphetamines, herbal or homeopathic preparations with estrogenic or procoagulant ingredients, and family history of consanguinity and also ethnicity such as Turkish or Middle Eastern for Behçet's disease. Now, if you look at the mechanisms which lead to clinical manifestations in CVT, there are two different scenarios. One, when there is a thrombosis of the cerebral vein that causes increased venular and capillary pressure, or when there is a thrombosis of the cerebral venous sinuses, there is reduced CSF absorption. In both these situations or scenarios, there is increase in the intracranial pressure, which leads to cytotoxic and vasogenic edema, which causes disruption of the blood-brain barrier, which causes even parenchymal hemorrhage in situations and hemorrhagic inflammation. So this is basically the pathophysiology. The clinical presentations are varied. Headache is the commonest symptom. It can present with a subacute encephalopathy, which depresses levels of consciousness, sometimes seizures, and usually they are seen with involvement of the deep venous system. They can present as isolated intracranial hypertension with symptoms such as headache and vomiting, or a focal syndrome such as hemiparesis, or a cavernous sinus syndrome, which is characterized by ocular signs such as orbital pains, chemosis, proptosis, and oculomotor palsies. Now, there are clinical pictures which are associated with certain sinuses and veins producing this kind of a picture gives us some clue. For example, as already mentioned, cavernous sinus thrombosis, it's mostly the ocular symptoms. Then there is sometimes facial numbness with the involvement of the ophthalmic and max divisions of the fifth cranial nerve. There could be fever, especially if there is septic thrombophlebitis of the cavernous sinus. Sagittal sinus usually presents with ICP elevation, headache and papilledema, seizures, and also focal deficits due to venous infarctions. Motor deficits are usually bilateral. There could be hemisensory loss or aphasias as well. Transverse sinus presents with headaches, raised ICP, seizures, aphasia if it's in the dominant hemisphere, contralateral pyramidal tract signs and symptoms, and limb and gait ataxia if it extends into the cerebellum. Sigmoid sinus usually presents with pain in the mastoid region and also cranial nerve 6, 7, and 8 palsies. Cortical vein thrombosis can present with motor or sensory deficit depending on the location, or a seizure and headache, but not necessarily papilledema. Deep venous systems, such as the straight sinus and its branches, for example, usually the symptoms and signs are severe and they present with a coma or alterations in mental status and motor deficits, which could be bilateral or fluctuating, alternating paralysis. Now, this paper, which was co-authored by the chair of today's program, which is who is Dr. Girish Kulkarni's paper, which came out in 2017, which shows the various headache characteristics with CBT. So the localization of headache could be anywhere on the head. You can see that it could be holocranial, parieto, occipital, temporal, neck, temporal. So it could be essentially anywhere in the head. Doesn't have any localizing value. And the descriptions can be throbbing, aching, pressure alone, weight, heaviness, band around the head, sharp sitting pressure. So the description of the headache, as you can see, it can resemble many of the primary headache syndromes, and therefore it doesn't have any sort of value when it comes to descriptions in terms of diagnosing CVTs. And factors affecting headache, relieving factors such as sleep and lying down and sitting, it could vary from patient to patient. There could be aggravating factors such as Valsalva maneuvers, such as cough, standing up, straining, or head movement, and also lying down. As you can see, postural, both standing up and lying down, both can be associated with presentations of CVT. And of course, bending forwards and nocturnal worsening. The headache phenotypes, they can present with a thunderclap headache, or they can present with a migraine kind of phenotype. They can present like a cluster headache. They can present with headache due to raised ICP, which is headaches, vomiting. And they can present like a tension type headache. As we saw, the characteristics can be any of these. And also orthostatic headache, which is headache which is increased when the patient is in the upright position. Now, headache mimicking migraine, so a very common presentation. They can present nausea, vomiting, and phonophobia are the most frequent associations. And in sigmoid sinus thrombosis, there could be unilateral tinnitus or unilateral headaches, again mimicking migraines with or without aura, or sometimes even cluster headache, especially if it's localized in the V1 distribution of the forehead and the eye region. And all of the process, if you look at how it produces the manifestation, even when there's no raised ICT, the migrainous manifestations are because of the inflammation, the distension or traction of any of the intracranial pain sensitive structures in the head, for example, irritation of the nerve fibers in the walls of the occluded sinus. The headache mechanisms in CVT are distension of the veins and sinus due to venous sinus occlusion caused by thrombosis, which determines the distension of the pain-sensitive structures of both the veins and the sinuses. There could be a combination of raised ICP, subarachnoid hemorrhage, and stretching of the nerves in the sinus walls and inflammation of the sinus walls. Venous infarction due to obstacle to the blood reflux causes cortical hematic infarcts, and this results in subsequent cortical irritation and inflammation. Unilateral headache is twice more common than diffuse or localized headache, but unilateral pain had no association with the site of the thrombus. And these findings suggest that multiple mechanisms are actually involved in the presentation of headaches in CVT. Now, CVT and dural AV fistulas are important. They're presumed due to be the opening of the AV arteriovenous pathways in the wall of the sinus during the occlusion or during the recanalization. The prevalence of DAVF is around 2.4%. Most DAVFs are diagnosed simultaneously or subsequent to CVTs. Patients are generally older, more with sigmoid and transverse sinus thrombosis, and more on the left side. Important to detect the fistula early for treatment with embolization with liquid embolic surgical or radiation therapy. CVT can occur during the development of an AV fistula. And headache may be a result of the DAVF as well as a consequence of intracranial hypertension due to a decrease in the venous outflow and concomitant sinus thrombosis or dural stretching. Spontaneous intracranial hypertension and CVT. CVT can occur as a complication of SIH in 1 to 2% of the cases. That is, decreased intracranial pressure leads to venous dilation, decreased blood flow velocity. Another possibility is cerebral venous traction due to brain descent, which leads to venous injury, stenosis, or occlusion, resulting in thrombosis. Now, this presents an orthostatic headache. This is the exact opposite of the other headaches, which are recumbent headaches because of raised ICP in CVT. When a patient presents with an orthostatic headache, suspect SIH along with CVT. So they are relieved with recumbency, and often they worsen by Valsalva type maneuvers and also with standing. CVT often develops several weeks after the onset of SIH, but there are few cases or reports that describe during the acute phase of SIH itself. Isolated cortical venous thrombosis presents with headache, papilledema, which is less common. And venous outflow through the large sinuses is not affected, and therefore intracranial hypertension is less likely. Parenchymal brain lesions such as localized edema, hemorrhagic infarcts are more often than in patients with cerebral venous sinus thrombosis. MRI T2 star gradient echo sequence, the most sensitive technique to demonstrate the presence of a thrombus in a cortical vein. Now, how do you differentiate between intracranial sinus venous thrombosis related isolated intracranial hypertension versus idiopathic intracranial hypertension? It is difficult to differentiate, except for in a study which came out of Sri Chitra, which showed, compared patients with MRI confirmed ISVT and true IIH. Both of them presented with raised ICP, normal CT and normal CSF composition, but no clinical features reliably distinguish between the two except female gender, more common in IIH, and low CSF protein. These are the two different parameters. And ISVT is often associated with head injuries, otitis media, Behçet's disease, and a variety of hypercoagulopathies and hyperviscosity syndromes, but maybe an elusive in a significant proportion of patients. So IIH should be a diagnosis of exclusion, even if they present with features of raised ICP, including radiological features. So when you have a suspicion of CVT, a clinical presentation, then what are the different ways in which you approach? One, of course, is the brain and cerebral venous sinus imaging, MRI with T2 star, MR venogram, CT with CT venogram if its MRI is not available. And when there is no evidence for CVT, consider the diagnosis such as stroke, IIH, meningitis, brain abscess, brain neoplasms, mitochondria. When CVT is confirmed, look for mass effect midline shift, signs of herniation, which requires urgent decompressive craniectomy. And etiological evaluation, that's when we look for otitis, mastocytitis, facial infections, dehydration, head trauma, stigmata of Behçet's syndrome, sarcoid, ulcerative colitis, malignancy, rheumatologic conditions, and exposure, as we mentioned in the initial slide about OCPs, chemotherapeutic agents, COVID vaccinations. Laboratory tests would include all of this: hematocrit, complete blood count, renal function, urine analysis, pregnancy test, prothrombin time, activated partial thromboplastin time, additional tests such as ESR, D-dimer level, iron studies, hypercoagulation panel, antiphospholipid panel, COVID-19 infection, MTHFR gene mutation, homocysteine levels, and protein electrophoresis. Once confirmed, then initiate parenteral anticoagulation with subcutaneous low molecular weight heparin, which is preferred, or unfractionated intravenous heparin. And look for either a stable CVT or whether there's progression. The thrombus propagation, consider endovascular therapy such as intrasinus thrombolysis or endovascular thrombectomy. And if it's showing a stable CVT, then transition to oral anticoagulants with direct oral anticoagulant or warfarin. Duration of oral anticoagulant therapy depends on the etiology. 3 to 12 months for transient predisposing factors, high-risk thrombophilia, recurrent VT, indefinite oral anticoagulants. How do you monitor visual symptoms of raised ICP in a CVT? The prevalence is 13 to 28%. Incidence of visual symptom, blurred vision, transient visual obscurations, diplopia, papilledema. Initial and follow-up exam, the baseline ophthalmological evaluation, and then follow-up at 4 weeks and 3 to 6 months. Even if papilledema is not present initially, some patients develop late onset papilledema even after full venous recanalization resembling IH. So this is a patient who I saw a few days ago, a 44-year-old male who presented with headache, which started from May 2025. And in July, he had few episodes of transient numbness of the right side of the body lasting for around 5 minutes over 4 days, which happened recurrently. And there were 2 episodes of probable right focal seizures with generalization. He was diagnosed to have a CVT, sagittal vein and paracortical veins. There was documented photophonophobia in a hospital where he was initially treated as migraine. Currently, there is no stimulus sensitivity. The headache increase on lying down. There's no nausea, vomiting, no visual symptoms. There is redness of the left eye during severe headaches. The onset of the headache is left periorbital more than right periorbital with a burning vertex no Valsalva worsening. He had a head injury 4 years ago with no loss of consciousness. He's currently on Diabestra 150 BD, Dicorate, and Cipla and Triptomer and Naxdol. And this is his MRI, which shows over here, what you can see is there's loss of the T2 flow void in the right sigmoid sinus and also the superior sagittal sinus, and irregular filling defects in bilateral transverse sinuses and the straight sinus and the torcular hierophily, and also the right sigmoid sinus, which is extending to the internal jugular vein, and venograms showing partial loss of flow-related signals in bilateral transverse sinuses. There is dural thickening and enhancement along the tentorium cerebelli on both sides, again possibly pointing towards the venous stasis, and punctate all hemorrhagic foci in bilateral frontal lobes with congested venous channels in bilateral frontotemporal lobes. There's a partial empty cella noted, prominent CSF space around the trigeminal nerves in the Meckel's cave, and also prominence of subarachnoid spaces around the optic nerve on both the sides without any kinking of the nerves, with subtle bulging of the optic disc on both sides, concerning for papilledema. And again, partial empty cella, venogram showing hyperplastic left transverse sinus and sigmoid sinus with moderate focal narrowing along the distal transverse sinus on both sides. No significant perioptic CSF distension, no posterior scleral indentation if you compare the scans between July 2024 and October 2025. Now, ophthalmological investigation showed um, a B-mode ultrasound showing bilateral subarachnoid fluid. And OCT, there was RNFL thickening in both the eyes with normal macular GCC in both the eyes. So, what is the diagnosis in this patient? It could be any of these, right? In a patient who had a CVT now presenting with a headache. So if you look at all the various types of headaches which can happen before the onset of CVT, during CVT, and also after CVT, it's interesting to note that in patients with CVT, many of them never had any headaches. Some of them had tension type headaches, migraines, or mixture of tension type headaches and migraines. And during the CVT, there were CVT related headaches, and sometimes there's no CVT related headaches as well. And then later on, some of the patients do not have any headaches, but some of them have headaches which can present as de novo tension type headache or worsening of their previous tension type headaches, or de novo migraines or worsening of their previous migraines, or secondary headaches due to dural AV fistula formation, or secondary headache due to intracranial hypertension, or secondary headache due to worsening of the CVT. So what is the final diagnosis in that patient who I saw? That is secondary intracranial hypertension. So with that, I conclude today's lecture. Thank you very much for your patient hearing.